Hello, today my presentation is on TAVI, current evidence and how to do it. This lecture was presented recently at the Brazil TVI meeting in Porto Alegre. Here are my disclosures. So we know the valve durability depends on a number of factors, and one of which is patient's life expectancy. So you can see that here, if you're age 65, you probably want the valve to last 20 years. If you're 70, at least 15 years. In your 70s, 10 years. In your 80s, probably 5 years would be sufficient. So how do we plan to get someone to the mid-80s? I mean, that's really the biggest question. This nice European Heart Journal review recently showed that maybe some of the potential sequencing options and the pros and cons, depending on your patient's age, on prosthetic valve, assuming a TAVR valve lasts 10 to 15 years and a TAVR valve lasts about 10 years. And you can see that if you are age 55, you really need to have probably 2 valve interventions in your lifetime, rather than if you're 65, you might end up getting 1 reintervention. And of course, if you're older, in like 75, you might end up getting 1. And if you're lucky, maybe you need another one if you outlive your valve. In the United States, you can see that the TAVR volume is increasing, and I would say that probably last year is over 100,000 cases. But also TAV volume has also steadily increased. You can see that over time. Now, the incidence of repeat TAVR procedure, I would say, remaining relatively low. You can see that it's about well less than 1%. This is based on United States Medicare data with reasonable mortality and stroke risk. And this is the Yuri Landis redo-TAVR registry, also showing that for failed TAVR valve, not the procedure. So these patients were done after the valve has degenerated or other reason, is well less than 0.22%. However, you can see that here, looking at which valve you put in, either first or second, with the same registry, interestingly, there is a difference in terms of gradient. So if you have the first valve being balloon expandable valve, you might end up having higher gradient. If you put your second valve also being a balloon expandable valve, you also likely result in higher gradient. In our explanted redo-TAVR registry, where it's going to come out shortly in JACC intervention, you can see that for us, there's really no difference in the use of balloon versus balloon non-balloon, whether it's first or second valve, and really the mix is pretty even between the two groups. And you can see that here, interestingly, in terms of mechanism of valve failure, in terms of redo-TAVR versus TAVR explant, if you have more structural valve degeneration, you're more likely to redo TAVR. However, you have severe PPM or prosthesis patient mismatch, you more likely need to have a TAVR explant because the TAVR valve in place is not going to expand much further to improve the PPM, unlike what you see with surgical valves, where you can do balloon valve fracture. We all know about the VAC3 definitions now about prosthetic valve dysfunction, and also in terms of hemodynamic changes and hemodynamic deterioration, ultimately leading to prosthetic valve failure or structural valve degeneration. However, not all prosthetic valve dysfunction can be treated with redo-TAVR. This is a nice redo-TAVR review that shows that if you have structural valve deterioration, certainly there's no concern about anatomy, you can do redo-TAVR. But if you have valve thrombosis and endocarditis, certainly redo-TAVR would not be indicated. If you have severe PPM or PVL, then it really depends on whether redo-TAVR is feasible. However, of course, with severe PPM, you cannot fracture any transcatheter valve, so you most likely need to have TAVR explant instead. There are a number of factors depending looking at TAVR and TAVR feasibility. This paper from JACC Imaging showed that you need the STJ width, you measure the leaflet height of the first valve, and your implant depth of your first valve. And you can see that here, you don't want to seal off the STJ, causing sinus sequestration and coronary obstruction. And this paper from Raj Makar's group, you can see that that's the reason why you cannot do TAVR and TAVR. If you seal off the aortic root, you really have no other option in terms of bailout. So this is very important to look at in the imaging. Even in fluoroscopy with balloon expandable valve, it does not guarantee you to able to do redo-TAVR. This paper, we look at fluoroscopy and angiography of number of patients, showing that a percentage of patients actually cannot undergo redo-TAVR. And you can see that here, due to sinus sequestration risk. And this is consistent with finding from the MedStar low-risk trial, the balloon expandable valve, 13% cannot undergo redo-TAVR based on CT analysis. Now, I would say that BEV and SEV inside a balloon expandable valve is more feasible than the other way around in terms of TAV and TAV feasibility because of the risk of coronary obstruction, as you see here, but also you can see that with TAVR and TAVR with self-expanding, inside self-expanding valve, there will be a number of patients with high coronary obstruction risk. The other issue with TAV and TAV is that there are new vocabularies to learn. So for example, neoskirt height, leaflet overhang, index THV expansion, and leaflet deflection. And I'll go over each in detail. So neoskirt height was first presented by the Vancouver group, looking at when the valve is fully displaced with the leaflets. With the second valve, you need to see how tall these leaflets are going to be in terms of making a cylinder, what we call neoskirt height. However, neoskirt height depends on how deep your valve is implanted or how high you implant it. So for example, with this SAPIEN valve, you can see that here you've implanted the valve deeper, you could have a better clearance in terms of coronary compared to implant the valve higher. And now with the valves prefer being implanted higher to avoid pacemaker risk, this could become a problem for TAV and TAV. But also it depends on where the supraannular leaflets are positioned. You can see that here with the ACURATE neo2 valve, because the implant depth is at least 7 millimeters, your actual neoskirt height is only around 18 millimeters, not higher. Versus the SAPIEN 3 valve, if you implant the valve again a little bit deeper, your neoskirt height is going to be less. And also, of course, with the Evolut valve, if you implant the valve at 3 millimeter depth, your actual neoskirt height will be 23, not completely all the way on the inflow. Now, in terms of balloon expandable inside self-expanding valve, the optimal position to avoid coronary obstruction has now been looked at, and you can see that it depends on the outflow at node 4, 5, or 6. You can see that here the neoskirt height will change because if you have higher position, your tube graft will be positioned taller. So you need to take that into consideration. But also the valve also expands inside the Evolut valve. So you need to look at not just the height, but also the expansion in terms of the coronary obstruction risk. The other thing that we realized that there's leaflet overhang from the first valve if you implant the valve deep, second valve deeper, and that can impact on the hemodynamics of the second valve. What I mean by that is that you look at the figures on the left side, is that if you have the valve being deep on diastole, the leaflet from the first valve are actually partially closed. And if you have functional stenosis of the first valve, you can actually cause stenosis, residual stenosis, even with the redo-TAVR. And you can see that here, if you implant the valve at the outflow at node 6, certainly it'll be less overhang. And you can see that video here that is simulated of the valve being implanted deep. So you can see the Evolut valve closes, but still leave with a triangle versus the SAPIEN valve implanted deeper. So that could potentially impact on hemodynamics of the second valve. Now, the other thing about TAVR and TAVR is that the first valve might be underexpanded. So here's the example here with a 26S3 that was normally inflated. You can see that in the pre-TAVR CT, certainly we oversize a bit based on the LVOT and the annular area because the mean diameter is only 24. However, you can see the post-TAVR CT, the inflow, mid-frame, and outflow is only around 23 millimeters. So it's clearly underexpanded. You can see that here as well based on our measurement. And so what we have to consider is to optimize the THV expansion of the first valve to prepare for the landing zone of the second valve, because after the second valve is implanted, it's going to be harder to expand both transcatheter valves to optimize the hemodynamics. So what we did with this same case is to expand the valve first with a 25 millimeter ZMAP balloon. We did not do a 26 true balloon or 26 commander system balloon, Edwards balloon, because of the worry about aortic injury, because you can see we were quite oversized with the native anatomy. And that has been reported if you do that too aggressively. And so what we then, after this Evolut valve is implanted, is to post-dilate again to minimize the recoil, but also the frame to frame, meaning the alveolus to the S3 frame leakage between, not across from the first valve. The other thing that we looked at is the frame leaflet deflection by the second valve. So what we mean by that is that you can see with the acroneal valve, there's a bit of a protective crown at this level, so that the leaflets might actually being expanded beyond that dimension, especially use a balloon expander valve. And you can see that example here with the sapien valve, valve inside the acroneal valve. The leaflets actually are going displaced a little bit further outward, not in a cylindrical shape. So from a coronary obstruction standpoint, you need to be aware of that possible phenomenon as well. And this goes to the same with the evolute valve. You can see that here, the balloon expander valve inside, the outflow of the self-expanding valve, you can see that compared to evolute and evolute, it does not change much, but you can see that it clearly can expand a few millimeters, up to 2.5 millimeters, in fact, with the balloon expander valve inside the self-expanding valve. So that could risk coronary obstruction. Now, one thing we need to be aware of is when you do TAVR and TAVR, how do you access the coronaries? And you can see that that could be a challenging situation if you have valve in valve, especially with two self-expanding valve here, such as the evolute and evolute, because if the frames are aligned, then you will be more likely to be able to get back in, but the cells will be smaller. But picture a situation where you have the neoskirt, but also the frame are not perfectly aligned, which I can tell you there's really no way to achieve that during the procedure. Then you really have much less chance of being able to engage the coronary, because you need to use a smaller French catheter to re-access the cell. So this could clearly be a problem in terms of coronary access with TAVR and TAVR. And also commissural alignment is important. This editorial written by us, you can see that if you have a shorter valve, then the commissural orientation of the second valve, which is taller, will matter. However, if you have a taller first valve, then you ideally want to put it in first with commissural alignment, such that with the second valve, you're going to have a better time with coronary access, because you already don't have the issue of commissural post facing the coronary with your first valve in place. So this is a state-of-the-art review that we published in JACC Intervention recently on workup of transcatheter valve in valve or TAV in TAV, and you can see commissural orientation is very important in terms of evaluating the feasibility, and you can see some of the CT parameters involved. I encourage you to read this paper in detail and also look at my YouTube channel, which you also find this presentation available shortly on my channel on YouTube, because we actually show you of TAV in TAV workup using the Freemancio software in both failed balloon expandable and self-expanding valve, particularly with the SAPIEN 3 and the evolute valve. So I encourage you to look at that in terms of detailed workup. Now, why do we need to review the pre-TAVR CT? Because we need to know the native anatomy. Is it bicuspid versus tricuspid? Is how underexpanded or the valve is relative to native anatomy? Did we oversize? Did we undersize? Because it's important in terms of how much we can post-dilate the first valve to prepare for the second valve. Especially, you can see that here, the second valve, especially the balloon expandable valve, should be sized to the native annulus on top of the first valve dimensions. And we can also use the first CT to look at coronary and sinus heights as references to determine the index THV implant depth. There's also other consideration in terms of redo-TAVR CT, the second CT, is that there could be motion of blooming artifacts. It can overestimate or underestimate the measurements. The frame expansion, under expansion, as I mentioned before, you might need to optimize the first valve before doing the second valve. The first valve may also be canted away from the center line, so you need to look at the angle, and potentially may make the coronary obstruction higher or lower. You can not, unfortunately, predict the frame expansion of the second valve from affecting the first valve, and also you can't really predict how much leaflet overhang, especially in stenotic stiff leaflets. This is not available right now. Now, I think fluoroscopy is probably as important, if not more important, than CT analysis, because you can see these three examples of failed SAPIEN 3 that the CT looks different from the fluoro. So, for example, the case 1, You can see the CT, the valve frame looks pretty high compared to the left main, but you can see on the fluoro, clearly the valve was implanted deep. So the coronary will be completely clear for valve in valve, and there'll be no concern at all. You can see on the middle case, this case number 2, it looks reasonable in terms of the coronary obstruction risk, because the frame, even though it's facing the left main, looks like there's a lot of space, but clearly there must have been a motion artifact, because you can see now on fluoro, look at how close now the frame of the S3 valve is to the STJ. So in this particular case, in fact, probably TAVR and TAVR would not be doable because you would have completely obstructed the left main. And then case number 3, you can see again, this looks potentially favorable. However, you can see, you can see the frame is facing the top of the left main. Maybe you need protection, but you can see that here, the actual frame with the sapien valve is much closer to the left main, unlike the CT measurement of over 4 millimeters. So there might be concern of putting a second valve in, especially without commissural alignment, impacting on the coronary obstruction risk of TAV in TAV here. So in terms of sizing, we actually don't know the answer how you size, but this is a proposed algorithm from our paper. You can see that if you balloon expander valve, you typically use the same size within each other. If you have a self-expanding valve inside balloon expander valve, typically you would choose size or oversized, depending on what type of self-expanding valve you use. If the balloon expander valve inside self-expanding, then you really need to look at the CT of the first valve to look at the native anatomy as well. And of course, if you're self-expanding and self-expanding, you will use the same size unless you have a different self-expanding valve you use, that you might need to oversize. Now, commissural alignment is important, as I mentioned before, with the second valve as much as the first valve. And these are some of the techniques with the self-expanding valve on a cusp overlap view on how to achieve commissural alignment. And I'll show you a quick example here with a failed 20S3 due to paravalvular leak. You can see that here, this valve initially was implanted pretty well, but clearly there was some PVL and there was a waste. And you can see that here now with the TEE showing small to severe PVL despite the valve working fine. You can see that on post-CT now, the valve was clearly underexpanded with PVL. You can see the frame is only 18 to 19 or 20 millimeter, so it's not fully expanded. So we decided to post-dilate this because obviously that's the first treatment. However, despite the frame valve expanded, there's now central AI. So of course, we would have to now fix the problem with a TAV in TAV. And because of the coronary concern, we actually protected the left main, and we use a self-expanding valve because of better hemodynamics. And you can see that here, the valve might have been a little bit deeper, but we were concerned about coronary obstruction. We also not sure about whether we can do commissural alignment. So we actually deployed the valve at this step, and you can see, thankfully, there was no coronary obstruction, and we actually post-dilate to better improve the hemodynamics of the evolute valve. And you can see now the left main stent in proximity of the evolute. And so because of the previous left main stent, we actually ballooned the left main stent, and you can see the final result, very nice with actually very reasonable gradient post-op of 13. Patient went home in 3 days, so no issues. Now with leaflet modification or over left main protection, you may want to consider balloon-assisted basilica, because now you can spray open the leaflet of the transcatheter valve more, because these leaflets are not the same as a surgical valve leaflet. So you want to make sure that you're not going to obstruct the coronary when you put a second valve in there, because the leaflet folds in again afterwards. Now, there are potential other factors affecting redo-TAVR versus TAVR explant. This is a paper that our paper showing some of the considerations here in the table. And of course, we know that TAVR explant is potentially risky operation, as shown in our TAVR explant or redo registry coming out in JACC intervention in the near future. If you cannot explant the valve, one bailout option in surgery is to remove the leaflets, and then you put a second valve in there, because now you don't have the leaflets causing the coronary obstruction. So this can be a potential bailout approach with surgery. So in summary, redo-TAVR remains rare for now, but it certainly can increase in volume in the future. And we all need to know how to treat these patients. The redo-TAVR can treat SVD, PVL, but not severe PPM. We need to do meticulous fluoro and CT planning to evaluate TAV and TAV feasibility from the perspective of corneal obstruction. And we need to learn new vocabularies, as I outlined in this presentation, discussing TAV and TAV feasibility. And also we need to optimize THV index expansion before implant a second valve to optimize the second valve's hemodynamics and potential durability. With that, I'd like to thank you very much for your attention.